Good evening on this rainy, somewhat cold spring morning. Welcome to the final session of the late spring 2025 series of Delaware Mini Medical School. It's been great working with our colleagues at Christiana Care on this particular series. Welcome to you, whether you're joining through Zoom or you're watching through YouTube. If you are watching through YouTube, please make sure that you email Nicole Sabine and let her know, and I'll show you her email address here in a second. Nicole has put the link into the chat. If you're having problems with Zoom, suggest you switch over to the live stream now. Just a reminder, as always, this is a Zoom webinar, not a Zoom meeting, so you don't see each other. We don't see you. You only see the presenters, and we only see the other presenters and panelists. Please use the Q&A feature. Don't ask any questions of a personal nature. We will do our best attempt to answer all questions, both housekeeping and the clinical questions. This evening is a nice beefy presentation, so we're going to have a little bit less time at the end for questions, but we'll do our best to get through them. Just remember, if you have a question, likely somebody else does, so make sure that you're listening carefully to make sure that the question you're asking hasn't already been answered and asked by somebody else. You do need to stay through the entire presentation, but when the official presentation is over and the Q&A starts, that's the time when you can leave and you'll still be counted as being in attendance. At this time, we're going to turn it over to my colleague, Christy Handley, with the Sussex County Health Coalition to introduce this evening's speakers. Christy.
Great, thanks, Tim, and welcome to each of our speakers from Christiana Care. I'm going to start with Shanice Bedassie. She is a certified pathologist's assistant with experience in community, academic, and private institutions where she has played a vital role in disease diagnosis through surgical and autopsy pathology. As a Board of Trustees member of the American Association of Pathologist Assistants, she advocates for excellence in the field and strives to inspire and support failure STEM professionals or future STEM professionals. Shanice earned her bachelor's degree from Northeastern University and her Master of Science in Pathology Assistance from Rosalind Franklin University of Medicine and Science, and she works as a pathologist assistant at Christiana Care. Our next speaker is Dr. Thomas Chou. He is a pathologist at Christiana Care, specializing in surgical and autopsy pathology. He is board certified in both anatomic and clinical pathology. Dr. Chou graduated from the University of Pennsylvania Perelman School of Medicine. And last but not least, we have Dr. Mary Iacocca. She is a pathologist and has practiced clinical and anatomic pathology at Christiana Care for over 20 years. She is the laboratory director and the chair of the Department of Pathology and Laboratory Medicine. Dr. Iacocca received her medical degree from Virginia Commonwealth University School of Medicine and pursued her residency at the University of North Carolina Hospitals. I'm going to turn it over to our speakers. Welcome.
Wonderful. Hi, everyone. My name is Shanice Bedassie. Before we get into our case presentation, I just want to kind of give you a little background on how I got to my role and where I'm at today. As mentioned, I got my bachelor's at Northeastern University in Boston for biology. Originally, I thought I was going to be pre-med, and so that was kind of the route I was taking throughout my entire undergraduate degree. I did some internships within microbiology and sports rehab just to make sure that I knew what I wanted to do. I was always interested in pathology, specifically being a medical examiner and doing autopsies, things like that. I thought it was going to be really cool. And then at some point I realized that it wasn't for me personally. I did not want to go to medical school. And so after college, I worked in digital health consulting at a boutique consulting company in New York City to see if research was the way that I wanted to go. And while I didn't have access to a program like this, which seems awesome, and I wish I did, it would have really opened up a lot of doors for me, but I did have access to Google. And I honestly just Googled, what's in the field of pathology that's kind of close to being a medical examiner without the medical degree. And I came upon PAs. I saw it, I started shadowing, and then I just went for it. And I went to Rosalind Franklin. And since then, I have been working in a variety of institutes from the West Coast in California to the East Coast in Boston. And I absolutely love it. And I never turned back. So that's kind of how I got to where I am in my career. I'm going to pass it off to Dr. Chou to explain how he got there.
Okay. Well, hello, everybody. I'm Thomas. I'm one of the pathologists here at Christiana Hospital. It took me a while to really find my path into pathology, but going back to, I guess, when I was in high school, I really liked school in general. I liked all my classes, but I guess the classes that really excited me were the science classes. I just thought it was just really cool. Like everything made sense, and how you could actually predict different what the outcome would be for different situations just by learning science. And so that was really interesting. I was fortunately enough to be able to go to college at Johns Hopkins. I studied biomedical engineering as an undergrad. I think at that point in time, I had already kind of settled in and wanted to be in the healthcare profession. And so my interest when I was in college was where I really kind of started to develop an interest in the neurosciences. So I kind of did a little bit of research in neuroscience, and that I think kind of propelled me in the direction of maybe I was thinking, well, maybe I can be a neurologist one day. I applied to medical school, and I was able to get into University of Pennsylvania. When I was in medical school, I was still kind of open-minded about what I wanted to do. In the very first year of summer, when I was in medical school, I got a small grant from the National Institutes of Health to do some research work. So I found a laboratory, and it turned out, and this laboratory was studying brain tumors and Alzheimer's disease, and so I went in there and never really had any ideas about what pathology is all about, but it was a neuropathology laboratory. So while I was there during my summer, I shadowed the attending, who was a neuropathologist, and he when he had some frozen sections, I'll go run upstairs with him. And then it's just a eye-opening experience, and made me think about, well, maybe I should also consider pathology. But that experience led me down to the path of getting an MD and also a PhD in neuroscience. After I graduated from medical school, I actually did a couple of years of postdoctoral research as well. But eventually I decided I wanted to go back to doing diagnostic medicine. I went to residency at University of California in San Francisco. I did my anatomic and clinical pathology residency, and also did a year of fellowship in general surgical pathology. And at that point, I kind of, I really, I was kind of deciding between doing academic or doing full-time clinical work, but I really enjoyed doing diagnostic pathology. And I think, and that was ultimately what swayed me to decide to go into practice. So I practiced for a few years out in California, and ultimately decided to come back to the East Coast. And here I am. Mary, you want to talk about your?
Yes, absolutely. So good evening, everybody. So I also had somewhat of a circuitous route into pathology. I always knew that I wanted to be a doctor from the time that I was younger. My first exposure was my father was a doctor, and I did have the fortunate experience of being able to go on a house call with him when I was young. And that probably meant more to me than anything and directing me to want to go into medicine and be a physician. I was really impressed with his ability to walk into someone's house and see someone in crisis and help them in the moment. And I don't think he realized how impactful that was on my direction. So I always liked science in high school, and I really loved biology. So when I went to college at University of Richmond, I majored in biology and was very happy in Richmond. So I stayed in Richmond to go to medical school at the Medical College of Virginia, and stayed there also for internal medicine. So I started my internship in internal medicine thinking that I would be a primary care doctor and make that same kind of house visit that my dad made. Well, what I didn't realize was that there was this whole other field I had never considered. And during my internship year, I was on vacation with family in Florida. And coincidentally, the wife of the friends that we were visiting, she was a pathologist, and she got called into the hospital. And I jumped in the car and went with her. We went into the lab, and she had a biopsy to look at, and it was a lymph node biopsy. And she looked at it and very quickly determined that it was metastatic breast cancer in a lymph node. And I was so impressed that she could, number one, quickly tell that it wasn't lymphoma, and she knew it was carcinoma, and that she knew where it was coming from just by the look of it. And I thought that was really neat. So it occurred to me that what I really liked about medicine was the disease process, and how to discover what was going on with a patient was really fascinating to me. So at that point, I switched from internal medicine to pathology and moved from Richmond to UNC Chapel Hill. So I moved down to North Carolina, took that additional 4 years to do a pathology residency, and then did fellowships in cytology and surgical pathology. And that's how I became a pathologist. And I came up to Christiana a couple of years after I finished my fellowships. I was on faculty at Chapel Hill for a couple of years at the medical school, and was invited to come up here and interview by a former pathology resident classmate, and fit in with Christiana's team, and have been very happy here ever since doing diagnostic pathology. And we're happy to have Tom and Shanice on board. So at this point, we can go into our presentation. So I'm going to share. And let me know when you can see my screen. Is my screen visible?
You're good.
Okay. So this is the curious case of the toothy ovary.
Do put it in presentation mode. There you go.
How is that?
Yep, perfect.
Okay. So now my screen just went blank. What do
There.
you see?
Yeah, we can see it fine.
Oh, you can see it now. Okay. All right. So I need to back up because it advanced. Okay. You see that?
Yep.
Okay, before we get into the case presentation, I want to just do a really high-level overview of what pathology is. So in general, pathology is divided into anatomic pathology and clinical pathology, where anatomic pathology is, in general, the study of tissue, and we look at tissue under the microscope, where clinical pathology is also known as laboratory medicine, that mostly deals with blood and fluids, and often being tested on an analyzer, some kind of automated analyzer. Anatomic pathology is divided into three main subsections. The first is surgical pathology, which is the examination of tissues that are removed out of or off of a patient. Many of these do come from surgery, but some come from other places like skin biopsies or endoscopies like colonoscopy when people have colon polyps taken out. The tissues we get can be anything from the smallest biopsy, like a tiny skin tag or a tiny colon polyp, to entire organs. If we get prostate cancer, they'll take the entire prostate, Or for breast cancer, we'll get the entire breast with the associated lymph nodes. Sometimes we get more than one organ in a specimen. For example, if someone has colon cancer and it's grown into the bladder, we'll get both of those organs together as a specimen. Cytology is the examination of fluid specimens. The prefix cyto means cell. And so we're literally looking at individual cells or groups of cells on slides. And this often is what we use to look at specimens like the fluid around the lungs, which is pleural fluid, or the fluid in the abdominal cavity, which is peritoneal fluid. We also have the ability to do very small needle biopsies of solid organs and turn those into a fluid specimen because the bore of the needle is so small, we can smear it on a slide. So we can diagnose lung cancer or, something taken from, a lymph node where there's metastasis, and take a specimen out that is essentially turned into fluid, smeared on a slide, and we're able to look at those individual cells and make a diagnosis. Autopsies, that's the third category of anatomic pathology, and that is used obviously to determine cause of death. There's two main categories of autopsies. The first is forensic autopsies, and the second is hospital autopsies. We do the hospital autopsies, so we're looking for the cause of death in a hospitalized patient. For example, did they have a heart attack? Did they have a stroke? Did they have widely metastatic cancer that ended their life? Forensic autopsies are done at the medical examiner's office in Delaware. The main office is in downtown Wilmington. Forensic autopsies look for things like overdose, accidental death, suicide, homicide, even cases of neglect. So they're very different types of autopsies, but those are two different career paths you can take if you're interested in one or the other. Clinical pathology, from a very high level view, there's different sections of the laboratory. For example, clinical chemistry often looks at things in the blood, such as ions, sodium, potassium, calcium. These are all critically important ions for proper functioning of, for example, the cardiovascular system or the neurologic system. The heart needs certain calcium, values to be able to contract properly. The section of hematology will measure things like hemoglobin and hematocrit. So you know that hemoglobin is the molecule in the blood that carries oxygen, and it's critically important to have a sufficient amount of hemoglobin in your blood to be able to have oxygen carried to your tissues so you can carry out your organ functions. Transfusion medicine deals with blood products and investigating what blood products a patient might need, and also getting those products to them and infused in them. So in this upper right-hand picture, we see some packed red blood cells. We've got some A positive cells, some O positive cells ready, refrigerated, ready to go into a patient. They have to be cross-matched to the patient to make sure the patient doesn't have antibodies against those units. And so that's what the science of transfusion medicine determines. Transfusion medicine also gives things like platelets and cryoprecipitate. Microbiology is the section of the lab that looks at what infectious organisms are causing disease in our patients. We do a lot of cultures. We culture blood and urine. We also culture tissue, cerebrospinal fluid. In this bottom right-hand picture, this is a culture plate where something's been plated out. And from looking at that, it can often help us determine what the organism was that was in the sample that we drew. Molecular diagnostics looks at DNA, RNA, and proteins to determine cause of disease. Sometimes that's when we're looking for things that cause cancer, and sometimes it's when we're looking for infectious organisms. Two that we do in great frequency at Christiana are we look for hepatitis, like hepatitis B and C. We also look for HPV, which is the human papilloma virus, the virus that is known to be a significant contributor to the formation of cervical cancer. So we'll get into our case presentation. Our patient is a 28-year-old woman who came in to her doctor with right lower quadrant abdominal pain that she described as a dull ache. We'll look at this schematic, and in any schematic or image that you look at from a patient, it's always presented as if the patient is facing you. So the right is on your left and the left is on the right. So her right lower quadrant pain is down here in quadrant number 7. So if you were wondering about what could be causing her pain, obviously in the right lower quadrant, the appendix is there. So that's probably a number one thing to make sure she doesn't have appendicitis. Other quadrants have other organs associated with them. So you can see the kidneys are in the mid portion on either side, on right and left. The middle of the stomach can have GI issues, or the aorta. If there's an aneurysm in the aorta, it can cause mid-abdominal pain. The pancreas is slightly higher. The liver is on the right, in the right upper quadrant, and the spleen is on the upper left. So for example, if someone had an injury where perhaps they fell down skiing and came in with left upper quadrant pain, you'd be worried that they ruptured their spleen. Notice, however, that at the bottom, the pelvic organs, while they're midline, they can also radiate to both the right and the left. So an important part of her history, and her physician asked her, you know, have you had any nausea or vomiting? And she hadn't. She just has this dull ache. She's kind of not comfortable. So a physical examination was done, and her vital signs are normal, with a blood pressure of 125/72, normal temperature, no fever. Her pulse was normal at 72. And then her physician did an exam and found out that she didn't have a lot of tenderness in the right lower quadrant. So while she was experiencing a dull ache, when there was pressure, it didn't really increase the amount of pain she was having. And that's important because often appendicitis will give tenderness when you press down on the right lower quadrant. That really does elicit more pain. So it was determined that she didn't have what was considered an acute abdomen, which is when there's sufficient concern about the level of pain and perhaps distension that she might have to go to the operating room. So there was time to do more studies. So the first thing they did was draw blood, and this is where we come in to be a little bit helpful. So some blood work was sent off, and it was determined that her white blood cell count was normal, in the normal range. So that makes you think that, well, perhaps her appendix isn't really inflamed if she doesn't have an elevated white count. Importantly, in a woman who's in this age range, a pregnancy test is almost always done for abdominal pain. Her pregnancy test was found to be negative, and her hemoglobin was normal at 12.2. So there's probably not an ongoing slow bleed going on where she's losing blood into her abdomen. So how do the lab findings help change the differential diagnosis? And I know you all have talked about what a differential diagnosis is. It's what are the possible things that could be causing her symptoms. So we have to entertain the possible things in the right lower quadrant. And we've determined that without abdominal tenderness and without nausea and vomiting and without an elevated white count, it's less likely that she has appendicitis. Now, her pregnancy test is negative, so it's pretty unlikely that she has a ruptured ectopic pregnancy. So this schematic here shows how an ectopic pregnancy could have occurred. So here's the ovary, and here's the fallopian tube coming off on the right. This is the uterus with the inside of the uterine cavity. When an egg is released from the ovary, it travels into the fallopian tube, and normally it gets fertilized inside the fallopian tube. And the fertilized egg travels down the fallopian tube into the uterus and embeds in the wall of the uterus. And that is where the pregnancy takes place, or where it should take place. When it cannot pass all the way through the fallopian tube, it's called an ectopic pregnancy. Now, ectopic simply means in an abnormal location. So it is abnormal for a pregnancy to start growing in a fallopian tube here. The risk is that it can rupture, and when it ruptures, it can bleed. So it's really important to rule out an ectopic pregnancy. And with a negative pregnancy test, it seems pretty unlikely that that is what is going on. But what other organ could be the culprit? Well, remember, the ovary is sitting right here too. So in order to take a look at her ovaries, it's time to do some imaging. So she got a pelvic CT. And remember, right is on the left and left is on the right. So this is her right side, and her right ovary is pushed a little bit more towards midline. So here's her right ovary, and it shows a mass that is somewhat solid, but it's also somewhat cystic. So these black areas are cystic content. So it's pretty empty in these areas. But notice this bright white spot in her ovary. This bright white spot has the same density as the bone. So here are her pelvic bones, also quite bright white. So what is this? Well, that's actually teeth. So why would an ovary have teeth? Well, the presence of teeth in an ovary is really strongly suggestive of a diagnosis of teratoma. So her radiologist is very smart, and the radiologist says, well, I think this is an ovarian cystic teratoma. Well, what is a teratoma? A teratoma is a tumor that can grow in the ovary or in the testicle, as well as other places like the mediastinum, that can give rise to any of the tissue types in the human body because it comes from germ cells. Where does that word come from? Well, the prefix tera actually means monster, and oma means tumor or swelling. Why would you use the prefix tera or monster? Well, it's because it's this conglomeration of different tissue types that don't resemble any kind of organ or anything normal, all growing together to form this tumor that'll continue to enlarge until it's diagnosed and taken out. So she has an ovarian teratoma based on the imaging result that the radiologist suggested. So it was time to take her to surgery. So she went to surgery for what is a presumed benign ovarian mass, and they only take out the ovary. The uterus is left in place and no lymph nodes are removed. That's really important because she's young and she wants her fertility preserved. She'd like to have children someday. So with a benign condition like this, you leave in any organ that's not going to be affected. There is over a 98% chance this tumor is benign. So that is the appropriate surgery. The ovary is going to come out. It's going to come to us. It's very important that fertility is preserved because she has another ovary. And that is the beautiful part of having paired organs, such as lungs and kidneys and ovaries, is you do have a spare. So the ovary comes out and comes down to pathology. And this is where Shanice will tell you about what she found. I think you're on mute still.
Here we go. Sorry about that.
Yep,
Yeah.
no problem.
Great. So once it's received in the pathology lab, the surgical lab, there are a couple things that I then have to do to prepare it for the pathologist. I have to create a gross description, which is basically just like a written report of what it is that we have. And then I have to sample the tissue in order to sample what is normal tissue and anything of interest that might help with the diagnosis. So before I kind of go into what I did, or my colleague did per se, I want to show you on the left side and remind you guys what a normal ovary looks like. And so on the very left photo, you can see a uterus with the bilateral ovaries. And in this photo, I know it's a little hard to see, but they are about 3 centimeters large is what I'd say. And then the middle photo shows the cut surface of an ovary. It's kind of variegated. It's very solid. It'll be yellow. It'll be tan. That's what a normal ovary looks like. Now, what we have on the right is what is received, and I'm going to go more into what that is, but you can see a stark difference between the middle photo and the right photo. Next slide, please. I'm not going to read this, but this is an example of what a gross description is, and this is actually what was written for this case specifically. The gross description is a macroscopic examination, which means it's describing anything that's visible to the naked eye before we get to the microscopic examination. Sometimes a pathologist may not even have photos. In this case, we do have photos, but sometimes they may only have that gross description and the glass tissue slides that have that microscopic image. And so it's very important that this description has a lot of descriptions, and it has to have your size, your color. It should have any orientation, any landmarks. We also talk about texture. All of these things can help create a picture that is easier for the pathologist to make a description and a diagnosis. So next slide. This is the external view. So this is what we kind of heard about on the imaging. We have this huge ovarian mass, which is about 15 centimeters. And that is 5 times the size of a normal ovary. So that's something that is obviously indicative of some type of process. We also do see that it has an incision on the left photo, and that shows that it's not completely solid like the normal ovary I showed you. This was filled with some type of greasy yellow fluid, and you can kind of see there are solid components, but there's a lot of empty space, which correlates to the imaging we saw. Next slide, please. Now, I'm just going to point out some of the important things that kind of let us know that macroscopically it looks like a teratoma. The color difference that you see here is due to a fixation. So when we get it fresh, like in this photo, it's pink. The photo previously to that was after it was fixed in formalin, which just helps us preserve the tissue and make sure that we can kind of get viable tissue on the slides. What I want to point out here is to the right of the ovary, we do see dark hair admixed with a greasy yellow debris. And this was inside of that ovary. Or this lesion right here. And so what that tells us is if we have hair in the ovary, there's likely some skin cells somewhere in there, which normally would not be seen in an ovary. Next slide, please. Now, what you can see there, you see an outer zoom on the left, but we kind of see it a little bit more on the right. We do have that tooth that was also seen on imaging. So we have a well-formed white tooth in keeping with an incisor. And there were some additional calcified components that were underneath that tooth, but that's the second thing that we see. So first we saw hair with possible skin. Now we're seeing teeth and possible bone, all within this cystic ovarian mass. Next slide, please. And then the last thing I want to point out, which was kind of a third component of this ovarian mass, is this little kind of cystic structure that was filled with a fluid, and it has these little trabeculations here that are in keeping with muscle. And that's something that we also would not have seen in a normal ovary. And so in this gross description, the PA that did this case basically described not only the size, which was abnormal, but these three main components that they found that we know are not typically seen in an ovary. And each of these components were then sampled. A sampling goes between 1 to 2 centimeters, and they only take a small snippet of tissue that we think may be diagnostic, and it gets processed and then turned into a glass slide. Accompanying those slides is the gross description, and in this case, some of the photos. And that it then goes to the pathologist desk. Next slide.
Okay, so the slides come to us and we look at under the microscope. So this is an image of what it looks like under the microscope. So what we have here at the top is skin. It looks like normal skin. There's keratin here. You can see a hair follicle down here in the lower left, and the brown in the middle is the hair itself. You see another hair and cross section here. Then you see these glands around the pore, and these are sebaceous glands. So these are all elements of normal skin. We have hair follicles with sebaceous glands, oil glands in our skin, and this is normal looking skin in the ovary. On the right, there's a higher power view. The skin's a little compressed here, and there's a lot of keratin. So this keratin is the same as the keratin that comes off our skin and that flakes off in the shower, or, you know, if it's on your head, can turn into flakes of dandruff. But in the ovary, it has nowhere to go. So it builds up and turns into that yellow, greasy material that Shanice was showing on the gross image. To the left of it, we have cartilage, so another benign element. Other things that we can see in teratoma, epithelium that looks like it's from the intestinal tract, a high power view, a low power view on the right with inflammatory cells. This could be a biopsy from the GI tract if we didn't think it was, you know, we didn't know it was from the ovary. We also have examples of more cartilage, adipose tissue. On the right, we have bone. So we can see bone in teratomas. And then two elements we see microscopically, not infrequently. One is neural tissue. So this looks very much like brain tissue we get when we have a brain biopsy. It's a little bit more cellular, but this is neural tissue from a teratoma. And not infrequently, we see thyroid tissue. So these are thyroid follicles with thyroid epithelial cells, and in the middle is thyroglobulin that holds the thyroxine, the metabolite that helps us with our metabolism. So normal elements, but in a very abnormal location. Can teratomas be malignant? Yes, they can. There's two different ways that a teratoma can be malignant. One is if it has immature elements that are what you would see from a developing embryo. This is very immature tissue and could be from a developing embryo, but this was found in a teratoma. So this is an immature teratoma. So this is the less than 2%. And then we can get malignant transformation of benign elements. So that thyroid tissue I showed you, if that turned into cancer, the most common form of thyroid cancer we see is papillary carcinoma. And this is a papillary carcinoma that developed from thyroid tissue within a teratoma. So teratomas can be malignant, but the vast majority of the time they're benign. So they only take out the ovary, send it to us, and we look for these immature elements to make sure that they're not there. And then if we determine it's benign, the patient's cured, surgery's done. If it's malignant, they need additional treatment. Now we'll move on to a potpourri of pathology.
Okay, thank you, Mary.
Mhm.
For the next couple of minutes, I just wanted to give everybody kind of a overview of diseases. Pathology, after all, is the study of diseases. And it's not possible, of course, in this limited time to be able to do this in a very thorough manner. But we'll try to cover a few areas of interest that I think might hopefully help people have a better idea of what diseases actually look like. I think that's sometimes the easiest way to understand them. If you go to medical school, you would, a traditional medical school, you would spend the first 2 years of your medical school learning about what's normal and what's abnormal. And here we're gonna talk a little bit about what's normal and what's abnormal. There's a few select organs. First one we're gonna talk about is skin. And so I'm gonna turn it back to Shanice to let her tell you what skin looks like and skin diseases look like and how she processes those specimens.
Thank you very much. Yeah, so as Dr. Chou said, we kind of have to have an understanding of normal, what's abnormal, and a lot of microscopic diseases do have some key featuristics macroscopically that you can kind of say, this might be basal cell or squamous or et cetera. And so if you look at the photo on the left, starting from the top left, we have basal cell there, which you can kind of see as this pinkish red lesion with ill-defined borders, and sometimes you might see some vessels in it. Then moving to the right, we have squamous cell, which tends to have a very crusted, ulcerated look to it. Bottom right, we have Merkel cell, which is this vivid red, well circumscribed and sometimes raised lesion. And then to the bottom left, we have melanoma, which has this dark pigmentation that could have borders that are regular or irregular. And so these are things that I would typically make a note of in my description. And then if we move to the very right, I have both the top and bottom photo. This is an example of what might be received in the lab. This is a skin ellipse. And so in this one here, you see this pigmentation, which kind of looks very similar to melanoma. And the bottom right photo is how I would process that. And so I would put on ink on a specimen, and I'll do this for any organ. And ink basically allows a pathologist under the scope to see something of importance. A lot of times it may be a margin. It could be something that I just want to bring their attention to. And then I would cut it up. I would then have it processed and turned into a glass slide. And then they would go ahead and look at it microscopically to make an actual diagnosis. Next slide.
Okay, just to give a broad overview, one of the first categories of diseases that we see very commonly is inflammation. And inflammation can broadly be broken into two different groups. One is acute inflammation and the other is chronic inflammation. Acute inflammation is mediated by a type of immune cells that we call neutrophils, and they are commonly due to bacterial infection. And you can see here, this is an example of a skin that has been injured. To the top right corner, you can see the normal epithelium that lines the surface of our skin. And on the lower right hand side, you see that surface is gone. And in its place, there are lots of neutrophils. And this is also a regenerating skin. So this is not one where the cut had happened just a few minutes ago, but rather maybe a day later, because you can see that there are some epithelial cells that are trying to grow over and cover up that area that was injured. Next slide. So chronic inflammation, this is a biggie. This is something that most people don't know very much about, but in medicine, a lot of diseases, chronic diseases are in some way, in one way or another related to chronic inflammation. Chronic inflammation under the microscope, what that looks like is a bunch of lymphocytes. And you can see here in this section of the skin, unlike the previous ones that we've seen, it's very busy. In the lower part, beneath the epithelial surface, there are lots of lymphocytes. And then even up towards the surface, on the skin surface, we're seeing lymphocytes in a lot of different places. So lymphocytes typically are thought of as immune response cells to viral infections. But like in chronic diseases like arthritis, and even in more common things like heart disease, diabetes, they've been implicated in those disease processes as well. And so it's an area that we don't really know very much about, but a lot of research is being done to try to understand what is the relationship between lymphocytes and chronic ailments that affects, a large portion of the population. Next slide. Okay, and then next comes a category of diseases that are called tumors. And tumors can be divided into either benign or malignant category, where malignant is basically what we mean when we say somebody has cancer. Benign tumors is distinguished by the fact that these tumor cells, they grow, but they do not invade or spread into other parts of the body. So this is an example of a skin tumor that's very common. It's one of the most common skin tumors that affect people. It's called seborrheic keratosis, and it's completely cured once it's removed. Next slide. This is an example of what skin cancer looks like. This is, so unlike the benign tumor that we saw before, where the growth of the cells is confined to the surface, here in this slide, what you're seeing is the surface cells growing underneath that surface. It's growing in areas where it should not be growing into. And you can see also how disorganized this group of cells are growing. They have very jagged edges, and there's also this kind of pale connective tissue reaction. It's essentially scar tissue that's trying to block these cells from going deeper into the tissue. But unfortunately, the scar tissue is not strong enough. And if this is not removed, this could become very dangerous. So just cancers of the cells that line the surface of our body, both the outside and the inside. So what I mean is not just the skin surface, but also the your mouth and your esophagus, stomach, intestines, even the lungs. These cells, cancers that arise from these cells are all called carcinomas. Next slide. And this is just a higher power view of a type of skin cancer that we call squamous cell carcinoma. So these cells look very similar to the cells that are on the skin surface. Next slide. So we already talked a little bit about skin cancer. Skin cancer is really common. So in the US every year, we're seeing over 5 million cases of skin cancer. But besides skin cancer, the other more common cancer by site would be breast cancer in women, prostate cancer in men, lung cancer, colon cancer. Melanoma is another type of skin cancer, but that is a much more aggressive type of skin cancer. Bladder cancer, lymphoma, which is cancer of the lymph node system, kidneys, uterus, leukemia, which is cancer of the blood cells, pancreas, and thyroid. Next slide. Okay, so let's switch to our next organ. This is the breast. Shanice?
Yes, so for a breast specimen, outside of a biopsy, we receive two main specimen types. And so I'm going to start at the very top left. That is a lumpectomy, which is a smaller excision of your breast. So it won't be the entire breast, but it's just a portion of it that is of interest. In this photo, you'll see two metallic wires. They're called localization wires. And those wires basically help guide us as to the area of interest that was found on radiograph. And then if you go to the middle top photo, there's ink on this. And so as I mentioned before, the ink kind of designates an area of importance for the pathologist. And in this case, it's telling us orientation. And so what it'll do is certain inks will represent superior, inferior, medial, lateral, anterior, posterior. And then the very top right photo, I just wanted to show you guys what it looks like once you cut into the lumpectomy. Breast tissue tends to be very fatty. You'll have some fibrotic tissue in there as well. It should be pretty soft or rubbery to the touch if it's fatty or fibrous, respectively. And tumor, for the most part, tends to be very firm. It'll be pink, it'll be gritty, it'll be very, very different. And then what we do have on the bottom left photo is a mastectomy. And so this is a resection of the entire breast with axillary tissue. That axillary tissue is what you see right there, that's fatty, and that's just tissue that's underneath your armpit. It has a lot of lymph nodes in it. You'll see the skin with the nipple and all of that. The bottom right photo is how we would ink a mastectomy. And so typically you just ink that posterior or the very back aspect of it, because that's what's lying over the muscle. And then you would cut it as well. And so the cut surface looks very simple, similar to a lumpectomy. It's just a lot more of it. And we would sample that, and then that would be what you would see now histologically.
Next slide. Okay, so first of all, before we go talk about diseases, let's first take a look at what breast tissue looks like under a microscope. So breast tissue under the microscope contains ducts and lobules, so they're responsible. The lobules are responsible for making milk after delivery, and those milk products are transported via the ducts into the nipple. We also have other cells that include fat cells and connective tissue. So that's kind of what normal breast tissue looks like. Next slide. Okay, so breast tumors are actually very common in women, and fortunately, most of them are benign. And one of the most common benign tumors in breast is a tumor we call fibroadenoma. And this is an example of what a fibroadenoma looks like. So unlike that previous slide I showed you, here we're seeing what's missing is the fat and the connective, well, mainly the fat cells, and then also the lobules. And in its place, we're seeing all these little ducts and this fibrous stromal tissue in between. Next slide. Okay, so breast cancer. So this is an example of a breast cancer that had been surgically excised. So under the microscope, what we're seeing, in contrast to that previous slide, we're seeing these little abnormal shaped ducts that are kind of floating all around the connective tissue stroma. It's also invading into the fat, and this is not where they should be. Next slide. And under higher power, you can see appreciate these cells better. And also notice, but I think it's probably a little bit hard for you guys to appreciate at this point, is that these cells are what we call atypical. They have enlarged nuclei that are disorderly. They're not forming well-formed glands. And oftentimes they have little dots in them that we call nucleoli, and they have diminished amount of cytoplasm compared to cytoplasm is the material that's around outside of the nucleus. So this is a breast cancer that we call invasive ductal carcinoma. It's the most common type of breast cancer. Next slide. Okay, so normal breast tissue is hormone sensitive, and it expresses a hormone receptor called the estrogen receptor, and they will regrow in response to the estrogen receptor. In normal breast tissue, the expression of this receptor is low, and so you can see there's this kind of pale brown staining in some of these cells. And that's the estrogen receptor expression. Next slide. In breast cancer, however, they often will overexpress the estrogen receptor on their cell surface. And this will allow them to pick up even very low levels of estrogen and grow in response to that. So, so for women who are postmenopausal, when the estrogen hormone level is low, these tumor cells will continue to grow in that setting. Okay, next slide. Okay, so that's a quick overview of breast diseases. I just talked about the two most common types of breast tumors. Let's talk about next prostate, which is found in men.
Great, thank you. So I just wanted to give you guys an idea of where the prostate is, just because it is a lesser spoken about organ, but very important. And so if you look at the top left, you'll see the bladder, which is that red kind of balloon shaped organ. And then right below that, which is like a golden yellow, is the prostate. And if you see from the middle, you'll see this kind of mucosal lumen, and that is the urethra that's connecting from the bladder through the prostate into the penis. You'll also see that there's this pink kind of circular ovoid thing on the right. That is your seminal vesicle. And what is not shown here is also your vas deferens, which connect to your testicles. And so those are three tubes that kind of insert and meet into the prostate, and then they kind of exit through the urethra. Now the photo on the right will show that exact same picture, except now you see that the prostate is enlarged. And so this can be for a benign or it can be for a malignant process. And only way to really kind of do that, to kind of tell the difference, is to biopsy it, and then inevitably you do take the prostate out. And so on the bottom left, that is a photo of a real prostate there. You'll see the prostate, which is being circled. And then those two projections on the top are your seminal vesicles and your vasa deferentia. The middle photo just shows how it would be inked, and that's just the prostate bisected, still looking at the external surface. And then the bottom right photo, all the way, that is a cut surface of the prostate. And so what you can see here is it's tan pink. It's a little nodular, which makes sense because it was enlarged. There is this slight yellow discoloration on the bottom right quadrant that can be, reaction due to a biopsy. It could be a malignancy. It can be a lot of things, but it is an area of interest. One thing that is very interesting with the prostate, as opposed to other organs, is that macroscopically, it's a little hard to tell what the disease process may be. And so in this case, it's extremely important to sample it heavily and then also look at it under the microscope, as opposed to, for example, the skins, where I can kind of tell you based on how it looks, it may be A, B, or C. I cannot do that macroscopically with the prostate. Next slide, please.
Okay. Okay, so this is what prostate looks like under the microscope. This is what normal prostate tissue will look like. It's made of a lot of glands, and these glands produce a fluid that basically becomes semen, and so a number of diseases can affect the prostate. One of the most common is just enlargement of prostate as men age, and that's called benign prostatic hypertrophy. And it wouldn't look very different from what I'm showing here in this slide. Sometimes the glands will get very big. Oftentimes there will be inflammation, there will be lots of lymphocytes, but essentially the features are similar to what you see here. Next slide. Okay, prostate cancer. Prostate cancer is very common in men. This is a picture of what that looks like on low power magnification under the microscope. Prostate cancer, unlike the benign glands that you see around it, these are which are large. These are very small, kind of disorganized glands that are infiltrating through this organ. So usually prostate cancer is diagnosed at a low stage because we have a very sensitive marker for prostate cancer called PSA. But if picked up late or if it's a higher grade cancer, it can spread elsewhere. Next slide. And again, this is just a higher power view of what prostate cancer looks like. This is one that is on the lower grade end. And what we mean by when we grade prostate cancer, just like any other cancers, it's based on one of the features that we'll look into is how closely they resemble normal tissue. A well-differentiated prostate cancer would look like normal prostate glands, and ones that are poorly differentiated will be very difficult to tell. So, so as I said, prostate cancer is also hormone sensitive, and so it responds to hormone testosterone. And one of the ways to treat advanced prostate cancer that has spread beyond the prostate is to block the hormone with drugs. Next slide. So before I go any further, I'm just going to take a quick detour and just kind of talk a little bit about what we know about in terms of the science of cancer. So what causes cancer? We know that cancer is caused by changes in genes that lead to abnormal cell growth and spread. Most common type of change that happen to the genes is due through mutations. But some of the changes can also happen at a level that's just not involving DNA, actual changes to the DNA itself. We call those epigenetic changes. Cancer-related genetic changes can be of one of three types. They can be hereditary, so you could inherit some of those changes through your parents. They could, that's rare, it's very rare. They could be caused by environmental agents. So the most common environmental agents, and there are three different categories of those, can be physical, such as exposure to ultraviolet light from the sun, chemical, which would include things like smoking and alcohol, or biological, so a number of viruses, even some bacterial and fungal infections are considered carcinogenic. And then lastly, but this is probably the biggest category, just random mutations that happen during cell division. The cells in our body are constantly turning over, especially the cells that line the surface of our body, the epithelial cells, and that process is not foolproof. And mutations are constantly being introduced, but the cells have a very good mechanism to try to repair those changes. But when those mechanisms are also damaged by genetic changes, then that is how cancer can arise. Next slide. So here's a picture of, and I think, I don't know how many of you know about the chromosomes and how many chromosomes we have in our body, but normally we have 46 chromosomes, and they can be XX or XY. That would determine whether someone is a male or female in general. But in cancer cells, which is what you see on the right side, the chromosomes are just completely different than what you see and so this is a picture of a more advanced cancer, I should say. So not all cancers can show such dramatic changes, but you can see the number of chromosomes. For example, chromosome number 1 in that picture, there's 5 of them. And it's incredible sometimes when you look at these pictures that this cell is actually able to live and divide. Next picture. Okay, so let's talk about another organ in the body, and this one is the thyroid.
Great. So in keeping with fashion, on the left-hand side, you'll see kind of what a total thyroidectomy looks like. And so it's a little flipped. as Mary mentioned, the body, but you'll see on the left side, you'll see the left lobe. You'll see on the, I'm sorry, on the right side, you'll see the left lobe. On the left side, you see the right lobe. And then you have a connecting piece called the isthmus. Now, what I'll say is the right lobe tends to look of a normal size, but you can see there is a big difference in size for the left lobe. It also kind of looks a little bit bulbous, probably soft based on its look. It gives me cystic just by that. And so what will happen here is we would ink this specimen, and then the top right shows you the cut surface of one lobe. So the red-brown tissue that you see is what a normal thyroid would look like. The grayish-white kind of mottled looking throughout is what an advanced tumor would look like. That is not normal. That is clearly some type of process. And in this case, it's spread very much throughout the case. It's pretty advanced. And then on the bottom right, this is also an example of a thyroid that looks drastically different from what we see both on the top and the left. And this is a goiter. And so what you see here are multiple nodules that have variegated colors. So they'll kind of look tannish yellow. Some of them look reddish brown. There's some speckling of red all throughout. They're in varying sizes. And it's throughout the entire thyroid. We do not see any normal thyroid tissue here. And this is what macroscopically would look like a goiter that has to be heavily sampled just to ensure nothing's going on. And that's kind of some of the typical sections that you would see in a thyroid.
Okay, so thyroid is, for those of you who don't know where it is, it sits right beneath your Adam's apple, and it's usually it's very difficult to feel it's there at all, but it's quite common for nodules of different kinds to form in the thyroid, and people can feel them. They'll go to the doctor and have it checked out. One of the most common causes for having bumps in your thyroid is a condition called goiter, as Shanice had talked about, which is basically caused by iodine deficiency. The thyroid makes a thyroid hormone, and in order to produce that hormone and secrete that hormone, it needs iodine, which is an element that we take in through food. And when there's iodine deficiency, that material cannot be produced. The thyroid hormone cannot be produced and released. And so the thyroid just gets bigger and bigger. And here you're seeing all these big islands of colloid basically stuck there because they can't be secreted into the body. Next slide. However, a small percentage of lumps and bumps in the thyroid are due to cancer. Obviously, we don't want to be cutting every lump and lumps from people's thyroids because most of them would be benign. And so one way that we can try to figure out which ones need to undergo surgery and which one can just be left alone is through a process we call fine needle aspiration, which is a minimally invasive technique where you just basically use a needle that's used to draw blood to try to aspirate some of the cells out. And here you're seeing a picture of what that looks like under the microscope. And in this example, this is a papillary carcinoma. And you can see in that center group, the cells have they have enlarged nuclei. Some of these nuclei have little inclusions in them. And so these are features that help us make a diagnosis and allow us to better triage patients. Next slide. So histologically, so under the microscope, this is what papillary carcinoma looks like. Thyroid cancers, many forms are strongly linked to radiation exposure. In individuals who are victims of nuclear bomb and also live near nuclear power plant accidents, the incidence of thyroid cancer goes up dramatically. Next slide. All right. Before I go too long, I'll just make one more comment. So a lot of the tissue that you've seen, Shanice shows there's ink on the surface, and the reason we ink that is because under the microscope, we want to be able to tell the surgeon whether or not they have completely removed that cancer. So if we see tumor on ink, that's indication to them that chances are there may still be microscopic tumor left behind, and they may need to treat that patient more aggressively. Okay, lungs.
Great. So on the left-hand side, we'll see a pair of normal lungs. And so the left lung will have 2 lobes, and the right lung will have 3 lobes. And then on the right-hand side, what we'll see is a cross-section of the entire right and left lung. And so the left side of the right photo, you'll see normal lung. And what normal lung looks like is it's red, brown, it's kind of spongy, it has all of these kind of white spots, which are your bronchioles and your airways and things of that sort. In the middle, you have your bronchus right there that's connecting, allowing you to breathe and connecting both of the lobes. And then what we'll notice on the bottom right is this kind of polypoid, cauliflower-looking white lesion. And that right there is an area of interest. It looks dramatically different from the rest of the lung. It could be firm, it could be a little soft. In this picture, it looks like it's a little firm. And that right there is a tumor of interest that you would heavily sample.
All right, so obviously that picture was from an autopsy case because that's both the right and left lungs. So lungs, let's just take a look at what it looks like under a microscope. Lung tissue is made of branching airways, blood vessels, and what are called alveolar sacs. And so it's almost like bunch of like tree branches, the airways extending to the lung tissue, and eventually forming these alveolar sacs. Next slide. The alveolar sacs is where the exchange of carbon dioxide and oxygen takes place. And they're lined by very thin layers of cells with little capillaries that traverse between them. And that's how, through diffusion, oxygen gets into the blood and how carbon dioxide leaves the body. Next slide. Okay, so tumors of the lung can come in many different types. One of the most common ones that when people see them on chest X-ray is actually due to infection. And this is an example of a type of an infectious tumor, a pseudotumor, I guess some people will call it. It's a type of tumor we call the granuloma. And it's basically an inflammatory response to lung infection. And in this case, if you look at the picture carefully, towards the upper left side, you see this foreign structure that doesn't belong in our body. And so it is essentially, it's a fungus that has been inhaled into this person's lung, and and the body has noticed that it's being invaded by this fungus. So it's generating this enormous inflammatory reaction to try to get rid of it. But notice how big that yeast that spore is. It's much bigger than the immune cells in our body. And so to tackle a big foreign organism like that, the cells basically have to fuse together and form what we call a giant cell to try to take it down. And a giant cell can be composed of sometimes hundreds of cells that essentially fuse together and try to work as a team. Next picture. This is a special stain that we use to highlight these organisms. And in this case, this is an organism called Coccidioides. This is a fungus that is found commonly in arid climates in the southwestern parts of the U.S. And it would float around in the air, and when it gets breathed in some individuals, they would grow and multiply and cause this type of lung infection. Next picture. Next slide. Okay, next, let's take a look at an example of what lung cancer looks like under a microscope. So lung cancer is the deadliest cancer for both men and women, even though it's not the most common. It is strongly linked to tobacco smoking. In this picture, what we have is lung tissue on the left-hand side of this picture. And on the right-hand side of this picture is a tumor. And let's take a look at higher power to see what kind of tumor it is. Okay, so this is what we call the poorly differentiated tumor. You can see obviously it doesn't resemble in any way, shape, or form what normal lung tissue looks like. This is a type of lung cancer we call small cell carcinoma. It is very aggressive, and unfortunately, even with the best of treatments, most patients will succumb to this cancer. It is strongly linked to cigarette smoking. Pretty much anybody who's came down with small cell lung cancer has been exposed to tobacco in the past. Next slide. Okay, so in terms of cancer death by different sites, I already said lung cancer is the most common. And this is followed by colorectal cancer, pancreatic cancer, and then breast and prostate. So, so they're actually lower down. So, so different types of cancers from different parts of the body, they are not all the same. Some cancers are more aggressive than others. And the job of the pathologist and what we do is spend a lot of time is to try to help the oncologist know what type of cancer they're dealing with and how aggressively it needs to be treated. Next slide.
So I think we can open it up to questions now.
Oh, okay. All right.
All righty, if you want to go ahead, let's leave this most common sites of cancer up. That's a good slide for a backdrop. So we do have a lot of questions, and I'm sure more will come in now that we opened it up. Is a mole considered to be a melanoma? Are some moles melanomas and some not? If so, how do they become a melanoma, or how do they grow like that?
Who wants to take that? Tom, do you want me to answer that?
Sure, you can answer it.
Sure. So moles are not melanomas per se. Moles are usually benign growths of melanocytes, the type of pigmented cells in the skin. And majority of moles do not become melanoma. It is possible for a mole to transform into melanoma. Melanomas can also arise de novo without the background of a mole, just, in the skin. So most moles are benign and most moles do not become melanoma, but it's very important to screen them to make sure they're not growing, to make sure they don't have irregular colors like blue and green, and they don't have irregular borders, because those would be signs clinically on someone's mole that it could be coming to melanoma.
All righty. There are a couple of different questions about the prostate. And of them, I'm going to choose this one. Is there a test to predict prostate cancer like the BRCA for breast cancer?
You want to take that, Tom?
As far as I know at this point, there's there are inherited hereditary factors involved in prostate cancer. But in terms of well-defined genes that are associated with prostate cancer specifically, and whether they can be tested, that I'm not very familiar with at this point in time. There may be, but I don't think it's something that is commonly offered at this point.
And was the question also asking about checking for prostate cancer as a screening test? Because if that is part of the question, there is the blood test, PSA, or prostate specific antigen, where that's a very common screening test to do on men that are middle-aged or older to check and see if it's elevated. Normally it's very low. When it becomes elevated, it can become elevated for either benign or malignant prostate conditions. When it's elevated, that often leads to prostate biopsies. So we get many of those biopsies. They're normally done about 6 at a time from the base, the apex, and the mid portion of the prostate on both the right and left side. So we get these 6 cores of tissue looking for cancer. If there's no cancer, then probably the cause of the elevated PSA is what Tom referred to as the benign prostatic hypertrophy.
Okay. Haley asks, how would it be to shadow a pathologist, and what would I need to do to set that up?
So the shadowing process takes place through an application that goes through academic affairs, and the application requires that you have a sponsor, and the PAs and the pathologists can sponsor somebody. There has to be someone identified that you can spend the day with. Generally, it's about 4 or 5 hours, and it involves standing both through the PAs as they grow specimens, as well as coming to the microscope with us and looking at slides under the microscope, as well as going into the clinical laboratories and spending time with the laboratorians there, including our clinical architect, a PhD clinical chemist who's great with the students. So there is a process to do that, and you can email us and we can guide you through the process.
All righty. How are HeLa cells used for cancer research? And before that, what is a HeLa cell?
So Tom, the PhD, can take that question.
Lucky Tom.
HeLa cell, okay, well, this, I have to jog my memory a little bit, but from what I recall, it's essentially a cell that was taken while the tissue was still alive from a cancer, and it has since then been propagated over many generations, and is used for a variety of research in the laboratory to both study cancer as well as other diseases. So yes, it is HeLa cell. My understanding originally was a cancer cell that came from someone, but
yeah, I think the patient that it came from, I believe she was cared for in Baltimore, so she wasn't far away. And it was named based on her name. Her name was Helen Lane. So they took the HE and the LA and called them HeLa cells. And they were really valuable to the researchers because they're immortal. But then they took this immortal cell line and they commercialized it. So it's for sale to do research with.
And I think actually the name was Henrietta Lacks.
Oh, was it Henrietta Lacks? Okay.
Yeah, Henrietta.
Yep, that's right. That's right.
Let's see. How common are iron deficiencies, and is one gender more susceptible than another?
It's not very common in the US because the salt that we buy is fortified with iodine. But iodine deficiency is quite common in many parts of the world. And it's not common to see a lot of individuals with goiter.
Okay. In women, is there a correlation between thyroid cancer and uterine cancer? Or for that matter, are there correlations between any cancers more commonly?
So so in women or men?
Just in women, the question is
In
about.
women. Okay, so there are correlations in cancers, and actually both men and women, but the correlations often have to do with genetic alterations. So for example, there's something called a P53 mutation, and that'll give rise to different cancers of epithelial cell lines. So we not uncommonly diagnose more than one type of cancer in a patient over time. And those cancers are often epithelial. So we can see someone with breast cancer who later comes back with colon cancer, for example. So cancers are correlated. And when they're correlated, they're often correlated for an underlying reason rather than sporadic.
All righty. And then going back to a slide that Shanice talked about, how long would it take an ovary, or for that matter, a thyroid gland, to get to the point that we're seeing it in the slides where you're doing sections to find out what's going on? Shanice?
Oh, so we're saying the question is how long it would take from, I guess, the point of concern from the patient to when it's on the surgery. I'm not quite sure how long the patient may be having, for example, the ovary growing. I think either Mary or Thomas would be better at answering that.
If you're talking about in terms of the time it takes from when we receive the specimen in pathology to when it arrives on a pathologist's desk as slides.
I think the question is, how long does it take for that kind of tumor growth to occur from the first day that you've got your first tumor cells to when you're seeing,
Oh,
tumor?
I see.
15-centimeter ovary, like how long does that take?
It varies. It really varies because, a lot of this process for cells to turn cancerous takes time. Sometimes when, for example, when we talk about cervical cancer, from the time when we first see precancerous changes in those cells to the time that it turned into, a bona fide cervical cancer can take decades. But since we do a lot of cervical cancer screening, we can sometimes pick those precancerous cells out at a very early stage. But some, but for other cancers, it's more obscure because it's very difficult to get that information. But, it takes multiple steps, multiple hits for cancers to develop. And sometimes it's just a matter of luck, how many of those hits happen along the way.
Right.
And in general,
and a compelling reason for having routine screenings.
yeah, and in general, benign tumors grow more slowly than malignant ones as a generality. So like in a benign ovarian cystic tumor could take years or a decade or longer to really cause a significant noticeable mass that the patient comes in for. But there are malignancies that grow very, very quickly. And one that is notorious for growing very fast is a high-grade lymphoma. So if someone has a mass in their neck that suddenly becomes very, very large, the risk is that it's malignant.
All righty. Are there medications that treat prostate cancer?
Who wants to take that? Do you want me to take it? So as Tom indicated, a lot of prostate cancers are responsive to testosterone. And so anti-androgen therapy is one of the mainstays of treatment of prostate cancer. And because prostate cancer is responsive to testosterone, another way to treat it is to do an orchiectomy and remove the gonads to prevent testosterone from being made. That would, possible treatment. There's also chemotherapy and also radiation can be used to treat prostate cancer. When
Sure.
prostate cancer is metastasized to the bone, which is one of the sites that it commonly goes to, radiation is often the treatment given.
All righty. So here's a question right from the pages of current news. Who would have staged the cancer of former President Biden, a pathologist or an oncologist?
So it takes multiple specialties to stage the cancer. So the staging, because it was, my understanding is metastatic to bone, the staging requires first a knowledge of where in the bone the tumor could be. So once he was diagnosed with prostate cancer, if there was a suspicion that it was in the bone, there are multiple specialties that would be involved. So imagers, looking at films of the bone would have a suspicion if there's bone lesions. Prostate cancer, when it goes to bone, often causes lesions that can be seen on images. Also, nuclear medicine doctors would look at a PET scan because PET scans show increased metabolic activity. So a PET scan would light up and become bright in areas where there was a bone metastasis. Then finally, they would involve the pathologist because they'd have to get a piece of that tissue and send it to us, and we would look at it under the microscope to confirm that it was indeed prostate cancer and not some other reason for the bone to have lesions in it. So it's sort of a multidisciplinary approach to come up with the final diagnosis of metastatic tumor, and then we communicate that to the medical oncologist.
All righty. We do have more questions that we're going to have time for, so I'm going to pick and choose the last couple. Something that I've actually wondered myself. So we talk about radiation treatment of cancer. What differentiates that radiation from the radiation that caused the cancer to begin with, and how does that complicated relationship work for choosing the right wavelength and the right duration and pinpointing it and whatnot?
So that's kind of out of our field of specialty. The people who give radiation are, a different medical field, but in general, radiation is effective at treating cancer because when cancer is growing, it has to be mitotically active. The cells have to be dividing. When a cell is dividing, that is when it's at most risk for being killed by an agent like chemotherapy or radiation therapy. So the radiation doses that they choose and how they target a specific point in the body are put into protocols that they've used over decades to determine the most effective dose, site, method to give it to be able to influence that particular type of tumor cell. Some of it is external, some of it is internal. You can have radioactive seeds that you implant in organs that cause radiation decay over longer periods of time. But it's based on the protocols and the studies they've done over long periods of time to determine what's the most effective way, dose, and method to deliver it for a certain tumor type.
Right. All
It
right.
really is like a double-edged sword, and it's essentially the same thing. When the radiation is creating cancer or it's killing the cancer cells. And so, for example, when they treat thyroid cancer, they don't use external beam radiation in general, but instead they use iodine, that is radioactive iodine. So they get selectively concentrated in the thyroid so that it's damaging those cells only.
Right.
Yeah, and there's several instances in which the type of radiation being given, it is known to potentially have the risk of causing a secondary tumor. So historically, one was patients that had Hodgkin lymphoma that affected their mediastinum would receive radiation, but they were known to be at increased risk for breast cancer later in life. Another is patients who have breast cancer and get radiation. For example, if they had positive lymph nodes and the tumor was spread outside their lymph nodes, they might radiate their axilla. Those patients get radiation effects on the skin, including like the skin of their breast or the skin of their upper arm. Those patients are known to be at risk of developing a malignancy of their blood vessels later in life called angiosarcoma. So it is very much a double-edged sword, as Tom says.
So all about the risks and the benefits. All righty. Going back to the title for this talk, last question. The tooth in the ovary, could she have ingested her own twin during fetal development?
Could you ask that question again?
So regarding the talk of the toothy ovary, could this have been the case where the surviving, the woman in this case, actually ingested her own twin during pregnancy, during
Oh,
development?
gotcha. So when that happens, when there is a twin pregnancy and one of the twins dies and it becomes, enveloped, that takes place in the uterus itself, not in the ovary. So the tooth would have been in a different place, but teeth don't grow in babies until they're about 6 months of life. Like that immature tissue was always there. That's where the germ cells grow, but there isn't a tooth in a very immature fetus in a pregnancy. So that there is a concept that a fetus that has died can be, absorbed by the other twin, but that would be in the endometrium and endometrial cavity, not in the ovary.
Right. All righty. Well, I'm sorry that we can't get to all the questions, but this has been fascinating. The PowerPoint presentation and the video will go up, probably the video tomorrow, and as soon as our presenters can get me the PowerPoint, we will post that as well. Did want to take the opportunity again to thank our colleagues at Christiana Care for providing the incredible depth of knowledge and expertise that we've heard this evening and throughout the series. And I'll also mention that the next mini medical school is going to be held in July. It's going to be during the daytime. Topics are going to be behavioral health, neurosurgery, nursing, diagnostic imaging, child life, and laboratory sciences. Thank you all for sticking in here with us, and hope we see many of you in the summer session. Have a good day. Bye-bye.
Thank you. Good night.